Well, like I see many people left. I guess they didn't like the lecture as much. No, I'm just joking. Okay, let's talk about something that is easier to understand, and that's kidney stone. And even if there is something you don't understand, you can go and read, and there is nothing complicated about kidney stones. I'm going to try to talk a little bit about some of the important aspects of kidney stone that could be asked in your board exam, but kidney stone is something very common. And in fact, I went to US for residency mainly because I wanted to work with Fred Coe at the University of Chicago, and he is and he was one of the experts, probably the most known expert in the area of kidney stones for many, many years. So this is a very interesting topic and something that is very close to my heart. I haven't been practicing so much with kidney stones dilemmas, but it's still a very interesting topic, how to deal with patients with kidney stone. We are not going to get into treatment as much, but some aspects of kidney stone that is important for us. So before getting started, I want to make sure that everybody understand the anatomy of kidneys. Do you guys know where kidneys are located? You know? Where are they? Well, not that specifically, but I mean more in in the back, in retroperitoneal. Okay, very good. That's all of it. And what is the name of this part? If you look at the exterior aspects of the kidney, that's the important part of the kidney. What do they call it? Cortex. And why is it important? Because all the glomeruli, which are the functioning as parts of the kidneys, are there in the cortex. So this part, which are like glomerulus up there, okay, that is all that starts here and then goes into what they're called. This one, which one? Okay, yes, that's actually true. But this is the papilla. Yes, that's exactly right. And then they go into minor calyces and major calyces, and then come down here. And what is hydronephrosis? Anybody knows? What is it? Hydronephrosis. Yeah. Anybody knows? That's true. And the reason you go by the name, but the reason is you have an obstruction, maybe a kidney stone here. So everything above that gets swollen and they get bigger. The kidney gets bigger. Okay. But that's called obstruction of the kidney, and that's a major complication of kidney stone. All right. So let's get started. So kidney stone is a common problem. It's a genetic problem in most of the patients, about 12% of men and 6% of women. In Middle East is much higher numbers. Most people, they have the first episode of kidney stone in the early 30s, and women have a bimodal age peaking around 35 and then at the age of 55. So these are not things that you really should know as much. But what happens when somebody has kidney stone? What do they say? They come to you, let's say you're in the emergency room sitting there, and somebody comes and had read all the signs and symptoms of kidney stone and comes to you and say what? Very, very good. They have flank pain. Very good. And this flank pain is moderate, severe. What type of pain? And usually you ask them from a scale of 1 to 10, how bad is the kidney stone pain? And yeah, there's people who have seen people with kidney stone, is severe pain. And it gets radiated to, yes, very good. All right. So these are more and less the type of patient that you see who would come to you and they said, I have kidney stones. My dad had kidney stones. My mom had kidney stone. All right. So in terms of what type of kidney stone are we talking about? And that's something that they ask you in your board exam. For practical purposes, many times, except for a specialized program or nephrologists, most urologists or primary care physician, they assume you have calcium oxalate kidney stone because up to 75% of all kidney stones are calcium oxalate. Okay. There are other types of kidney stone, but even they have some calcium oxalate within their kidney stone. So it's not like you have a kidney stone that's pure. Most of the time you have different things, and we look at predominantly what type of kidney stone is that. And predominantly by far is calcium oxalate. So many people who have kidney stones, without even knowing what type of kidney stone they have, we assume it's calcium oxalate and we treat them for calcium oxalate kidney stone. Okay? But there are other types too. There is one called a struvite, which is magnesium ammonium phosphate. And if at any time they tell you the patient had UTI and kidney stone, this is the type of kidney stone for your purposes they have, a struvite or a staghorn. And the enzyme, they have this enzyme urase that's causing the stone. Some stones are uric acid. If somebody, the complication of RTA, people who have RTA, a complication is kidney stone. And the type of kidney stone they have is not calcium oxalate, but is calcium phosphate. If somebody with RTA comes with kidney stones, or seems to be you have non-anion gap metabolic acidosis, and patient has, especially children, they come with kidney stone, they have calcium phosphate for your purposes. Okay? And then they are very interested in a genetic disease, which is cystinuria. And these are the patients who have cystine as the cystine crystal. So there are not too many types. If they don't tell you exactly what it is, you assume it's calcium oxalate. Yes. Yes. So let me just, so calcium oxalate, almost everybody for our purpose has calcium oxalate. Few people have this UTI. That would be if somebody has UTI and kidney stone, they have the staghorn or struvite. If somebody has RTA, okay, acidosis, and kidney stone, they have calcium phosphate. And the reason is because with acidosis, you have more calcium supersaturation in the urine, so they are prone to get kidney stones. Now, cystinuria and uric acid is that there are other types of kidney stones. So one typical question would be somebody comes to you and they show you one of these pictures, which I got from New England Journal of Medicine. Actually, Fred Coe wrote that part. So this is something that is very common. This is like a simplified version of it because many times you see different types of kidney stone and you have to figure out which one your patient has. The one in A that looks like an envelope for me, that is calcium oxalate. So if you see something that looks like an envelope, they are not going to show you anything complicated. They're going to show you straightforward pictures. So that is calcium oxalate. B is also calcium oxalate, but they're not going to show you. Anybody knows what this rhomboidal shape and like pinkish and D stone is that one? Uric acid. Very good. That's a uric acid rhomboidal. Usually they show the color picture. That's a uric acid kidney stone. If they show you what is known as coffin lid kidney stone, that's a struvoid. Okay, that somebody has UTI, they show you this picture, that is a struvoid kidney stone. And you have to treat the UTI for this kidney stone. And if they show you hexagonal type of stone, anybody knows what that is? It's the only one missing now. Which one? No, that's no, that is a struvoid. This one, the last one, hexagonal. Not coffin lid. Which one? Very good. That's a system, yes. That's a cystinuria. So the one that you guys have to remember, this hexagonal, which is very favorite of, I don't know USMLE part one, but definitely part two, because there are genetic diseases associated with cystinuria, they may ask you. Coffin lead, which is its true white, uric acid, and calcium oxalate. If one thing you guys should remember is this picture, because more and more there are going to be some questions about kidney stones and RTA sometimes. Okay. So if you look at calcium and you do an X-ray, you do see it, right? Because it's calcium. Uric acid, you're not going to be able to see it on X-ray. So if you do an X-ray on any patient, that typically nowadays, at least in US, we don't do X-rays anymore, right? What do we do if we think that somebody might have kidney stones? We are not sure. They come with flank pain. We typically, maybe in Europe, they still do urogram and X-rays. In US, that's not what we do. Yes, I mean before CT, we used to use ultrasound because ultrasound also is very sensitive. But you're right. Now most of the time we do a CAT scan just to see whether somebody has. And what's the reason for it? Isn't like a waste just to do CAT scan rather than to do X-rays? Why should we spend more money on CAT scan? Very good. That's exactly right. Because it's very hard. Not every patient has read the book and comes with all the signs and symptoms. Unless they have had recurrent kidney stone, then they know. They come to you and say, Doc, I have a kidney stone. So that you don't need to x-ray them. But sometime, many times, you don't know exactly what the reason is. You go to the CAT scan, not to make the diagnosis of kidney stone, except for how large they are, but also to make sure there is nothing else going on. Any questions so far? So I'm just going to put some of the things they ask you in your boards. Okay. The first thing about kidney stone, if somebody has RTA, calcium phosphate. If somebody has UTI, it's true white. Hexagonal type, cystinuria, and cystic. If somebody comes with this kind of stone, and these are what type of stones? Oxalate. Yeah, these are calcium oxalate. And they say the guy comes in, seems to be like out of it, doesn't remember where he is or she is, confused. You measure the anion gap is high, they have osmolar gap. And they say, well, what's happening to your patient? Why do they have the stone? Why do they are like confused? They are sick. What has happened to them? They have ingested. Very good. Excellent. Very good. Ethylene glycol. That is a very common question, not for your board, but also for even internal medicine board. That's a very common question all the time. Ethylene glycol ingestion, they get very sick. They have oxalate kidney stone, but they're sick. They are confused, sometimes in coma. They have high anion gap. Remember Kussmaul breathing. Okay. All right. That's calcium phosphate, also radio-opaque. And then uric acid. Uric acid, usually if it's pure, which is uncommon, it would be people who have very high amount of concentration of uric acid in the body. But usually any type of kidney stone, there is a component of uric acid. So that's something to remember. That doesn't mean they have uric acid kidney stone. That's part of the different parts of the calcium oxalate kidney stone. Okay, nice. True white, these are really big staghorn kidney stone. And as I just mentioned, there are two things that you guys have to remember. Not specifically which bacteria causing it, but these are your urease producing bacteria. That's the only thing you guys have to remember. And that these are big, okay? And UTI is the causing it. And the treatment is treatment of UTI. You don't have to do anything with the kidney stone per se, except that they are, if they are too big. All right. Cystinuria is, I'm not going to spend too much time, but if you see a younger person with family history of kidney stone, either they have RTA or they have cystinuria. Okay. And the difference is that with RTA, you have calcium phosphate. With cystinuria, you have this hexagonal. Hexagonal, remember that they mention usually is an hexagonal kidney stone. They have cystinuria. All right. And something, I don't know for you guys, but something that maybe down the road they may ask you, there are some medication that they precipitate in the kidney. These are not calcium, uric. These are just the medication itself. It gets saturated in the urine and gets converted into stone. Yes. What type of leucovorin you're taking? Oh, yeah, topical usually they don't cause a problem. Yeah. They have to be very high concentrations in the body in order to get precipitated in the urine. Yeah. And usually these are the medication that we use for like HIV patients or people who have herpes, but not to just put topical in it. You have to be very high concentration to get, and those are people usually that, let's say, cancer patients that we give them very high doses of this kind of medication because they are immune suppressed. So you want to protect them from getting infection. So if they ask you indemnivir, okay, acyclovir, and some sort of a stone, these are not calcium oxalate, uric acid. These are just like drug crystals, basically. Question so far? But this is just a medication for the HIV patient. All right. So what do we do for the patient? I told you more or less a patient. You don't worry about heart now because I don't want to make it too complicated for you. If they ask you, they are not going to ask you about heart medication, which are like it stands for different types of the antiviral medication that we give to HIV patients. But rather, they're going to specifically tell you somebody who got acyclovir, somebody who got indemnivir. Okay. All right. Now, I told you more or less what would be the history of a patient. The first thing we have to know after making the diagnosis, and the diagnosis would be through the history, physical exam, and then getting a CAT scan. The question would be, well, what do we do with the kidney stone? Okay, actually, before that, one major problem with kidney stone is that they come back. Okay. So if somebody comes to us for the first time and they don't have family history, we don't do an extensive background and order a lot of labs. But because many of them they come back after the second episode, we order a complete workup for them just to figure out what type of kidney stone they have. And I put like more and less what you guys have to remember, 20% by 2 years, just to remember two and two. That's not exactly correct, but more and less. 50% come back after 5 years with second episode of kidney stone, 60% by 10 years, and 75% with about 30 years. So it's very common to see people who have recurrent kidney stones. And why do you get kidney stones? There are two reasons for that. There is a thermodynamic effect, and then there is a kinetic effect. And I'm just going to go over calcium oxalate most of the time. But even without really thinking too scientifically about it, if you have calcium oxalate, kidney stone, or any type of kidney stone, there's just one major problem. Let's say calcium oxalate. Either there are just there are two reasons you can have calcium oxalate. At the end of the day, calcium oxalate kidney stone. Either you have too much calcium in the urine or too much oxalate. There is no other way. Okay. In the urine, you have too much calcium or too much oxalate. For uric acid, you have too much uric acid in the urine. For cystinuria, you have too much cystine going through the urine. Okay, then just the way it works. And why is that? Because there is something called supersaturation of any substance. And by that means that there is a saturation point that, let's say, calcium is still kind of dissolved. It doesn't get converted to the kidney stone. But if it passes that concentration, and the way we measure that, we have something called supersaturation numbers. If it's more than one, it's that when you calculate that, which is you guys are not going to be asking to calculate that, but they might make you, well, the supersaturation is more than one or less than one. If it's more than one, let's say for calcium, means that the patient is at high risk of having too much calcium in the urine. If it's less than one, that means, okay, the amount is not too much in terms of causing the problem. Normally, we don't measure supersaturation. We just measure the amount of calcium oxalate and other things in the urine. But in specialized centers, they look at supersaturation as a way to figure out whether you're at high risk or not. And more importantly, in your exam, they may ask you supersaturation number. If it's more than one or less than one, and what does that mean? Okay, the kinetic phase is that once you have supersaturation of calcium, you're at risk. The reason that you have kidney stone because that calcium goes around either epithelial cell debris, some cast, or some other crystal, and goes around it and makes a kidney stone then at the end. Okay? So it needs something to hang on to before you get the kidney stone. Okay, and so I just mentioned, okay, let's focus on calcium oxalate. So there are three determinants of whether you have too much calcium oxalate in the urine. Either you have too much calcium, or you have too much oxalate, or what else could it cause that? Very good, the amount of urine, because it is a concentration, right? So if the amount of urine is not good enough, the amount of calcium may not be high, but it is supersaturated just because you don't produce a lot of urine. All right. Now, the other thing that is true for almost all types of kidney stone, body has some defensive mechanism against making kidney stone. And the most important one is called citrate. Okay. And what happens to citrate, it binds to calcium and make it much more soluble than otherwise. So the more citrate you have in the urine, the better is for you. And in fact, when we see people with kidney stone, we give them citrate to take because that helps with making, once they have kidney stone, it's not going to do anything with kidney stone, but it helps them to prevent future kidney stones because it makes the kidney stone more soluble or makes the calcium more soluble. All right. So calcium oxalate. So why do you have calcium oxalate kidney stone? I said that there's three reasons, right? Either you have too much calcium, too much oxalate, or not enough urine. So what causes too much calcium, first of all? Why do you get too much calcium? What are the causes of? Because that's what we want to at the end figure out. Because many times it's just genetic. There is not much we can do except for board exam. There is one familial cause that they can ask you. But when we order things, when I see you, you come to me and say, well, I have kidney stone. I order few things, including your sodium, potassium. I look at the urine and measure calcium, oxalate, uric acid, cysteine, all the things that I just told you. But let's say if the normal amount of calcium in the urine is 300 milligram and you have 400, higher than what should be, you have hypercalciuria. That would be a risk factor for you. So what test do I do to see, well, why do you have so much of calcium in the urine? What do you think? All right. Well, one reason you have just too much calcium in the body and you're just filtering it. So you have hypercalcemia, right? That could be one reason. Or two, you don't have hypercalcemia. You just filter too much calcium in the urine. And that would be only hypercalciuria. If you have hypercalcemia, is there any hormone that could cause hypercalcemia? Excellent. Parathyroid hormone. So that's the thing we always measure. We looked at vitamin D, derivatives of vitamin D, and PTH to see why somebody has hypercalcemia, if that is the case. Okay. Now, people who have hypercalcemia also have hypercalciuria just because too much calcium in the body. They filter a lot of calcium. They dump some of that calcium into the urine. Yeah. But that's the things we measure. We measure some of the PTH, vitamin D, some of the medication that could cause that. But what else? If somebody has hypercalciuria, the only thing for your board exam they can ask you is the familial form of hypercalciuria, which you measure the 24-hour urine and you see a lot of calcium in the urine, but they don't have hypercalcemia most of, or very moderate hypercalcemia. That is when you have a mutation in the calcium channel. So you dump a lot of calcium in the urine. So if they ask you, well, if there is one test you have to check in a patient with hypercalciuria, check the 24-hour urine. Don't check the PTH or anything for your board exam because they are looking for to see whether you're familiar with this form of genetic form of hypercalciuria because they just clone the gene for it as well. So they may be interested to see how much you know about this type. How about oxalates? So with calcium, we said it could be hypercalcemia or hypercalciuria by itself. But how about oxalate? Who would get too much oxalate and secondarily calcium oxalate? Well, obviously somebody who is taking a lot of oxalate, right? Those people, like if they are taking, I don't remember, like beans, greens, I don't think they're going to ask you that. But what is very common, not here, but let's say when I was in Chicago, that's not uncommon because in cold weather, what people take in order to prevent getting flu. Very good. They get huge amount of vitamin C every day, and vitamin C is a precursor of oxalate. So these people could be at risk of calcium oxalate kidney stone, not because of calcium, but rather because of oxalate. By the way, in the past, even my time, when we had a patient with calcium oxalate kidney stone, we were telling them not to take calcium in their diet. We're trying to restrict the amount of calcium in their diet. But then we realized they get more kidney stone. And the reason is that then calcium, without calcium, oxalate gets more reabsorbed. So you get kidney stone, not because of too much calcium, but too much oxalate now. So nowadays we don't restrict calcium intake for our patient, unless you are taking huge amount of calcium, we tell them to be moderate, but we don't restrict it too much. Okay, the other thing they may ask you about oxalate would be somebody who has Crohn's disease, IBD, these kind of problems, because as I mentioned here, they may ask you something to that effect. Somebody who has Crohn's disease and they have kidney stone or gallbladder stone. Okay, both are common in those kind of patients. And that's because they have increased fatty acid. Calcium binds to this fatty acid. And if it binds to the calcium, to this fatty acid, it's not going to be binding to oxalate. So you have an increased oxalate reabsorption from the gut. And you may be at risk of getting kidney stones. Okay, there is also something called primary hyperoxaluria, which is a liver disease, and sometimes they get a liver transplant. I'm not going to spend too much time here, but just have in this name, just to think about it, if somebody, a pediatric patient, has severe liver disease and kidney stone. I think I covered most of the important thing with calcium oxalate here. Any questions? No? Okay. Now, before I finish the part with calcium, as I said, you can have secondary hypercalciuria. We measure parathyroid, sometimes thyroid, not that common. Renal tubular acidosis can give you calcium phosphate. Medullary sponge injury, don't worry, they're not going to ask you anything. But there are some diseases that also cause hypercalcemia. Okay, and they're going to ask you, it could be one of those diseases, especially sarcoidosis and malignancy, because those two are very commonly associated with hypercalcemia. Very, very common. Anybody knows why cancer patients get hypercalcemia? No, they actually calcium is low in tumor lysis, but that's a good thought. What else? You know, in high calcium in cancer patients, very, very common, and it goes very high. Well, yes, but why is that? They produce a hormone from the cancer cell very similar to PTH. It's not PTH, it comes from cancer cells. And that's the main reason they get hypercalcemia. Okay, don't forget sarcoidosis. That's also very common. What would be a typical patient with sarcoidosis who gets kidney stone? How would you know what patient will show you? Somebody who has hypercalcemia, obviously, but what is the one picture they may show you with sarcoid? You guys have studied sarcoidosis or not yet? Huh? Granuloma, yes, but where? In the lungs, yeah. They show you an X-ray with very prominent granuloma, and then with kidney stone or hypercalciuria, that patient has sarcoidosis. All right. And I said, like, we give them citrate in order to make it more soluble. Calcium phosphate, RTA, struvite infection. Okay, this evaluation, we already mentioned that. Some of them are radiopaque, that this one calcium oxalate or phosphate. The CT scan, I don't think they're going to ask any of those things for you. Okay. At the end, there are two things that we have to figure out. One is that whether we wait for the kidney stone to pass or we have to do some sort of intervention. And what do we do to prevent it and treat patients? Not acutely, but overall to make sure they don't develop as many kidney stones. Say it again? Yeah, definitely. Very good. But the first thing we always do, we give them fluids because fluids help to decrease supersaturation. It's just a question of saturation and concentration. You give them more fluid, the more urine they have, the less likely they develop kidney stone. But the first question is, well, if the kidney stone is, especially with its true white, which is usually big kidney stone, do you wait or you have to do something for them? Well, if the kidney stone is more than 7 millimeter, just remember this seven, then it's not going to pass by itself. You have to do something. It gets stuck, it's too big to pass through the kidney. If it's less than five or even five, you can wait. You can give some fluids to the patient, you can give them some morphine and wait to see whether kidney stone passes. And usually they do pass. Anything above 7 millimeter, you have to do something about it. Okay? Immediately, because that's not going to pass. And if it doesn't pass, it's called what? Obstruction of the kidneys, right? You get it stuck there and the kidney then not going to be working well. So remember that 7 minutes. So what do we do for the patient if it's not that big? We give them a lot of fluids. Every patient they ask you what type of juice should I be taking. Okay, there's no specific juice they should be taking. Just take them to have water, probably would work well. And also you limit the salt intake for them. And there are many reasons for it because of calcium and uric acid that goes with salt. You give them thiazide. Almost we give everybody who comes with kidney stone, especially if they go to a urologist, they give them fluids. They give them potassium citrate for obvious reasons we mentioned, and we give them thiazide. And why do thiazides work? How does that work? Okay. What happens to calcium then? Very good. What does Lasix? How does Lasix work? It's the other way around. So if somebody has hypercalcemia, we can give them Lasix because it increases the amount of calcium in the urine. That would not be good for our patient. But if somebody has kidney stone, we give them thiazide because it increases the amount of calcium reabsorption or decreases the flow of the calcium through the GFR. Okay, so thiazide, fluid, and citrate for everybody. If somebody has too much uric acid, we give them allopurinol. And if somebody has cysteine base, there is specific treatment now, but I think still if they ask you, you have to use penicillamine as the treatment for it. Antibiotic for struvite, and basically that's the way I approach a patient with kidney stone. All right, if something needs, yeah, yeah, you can do magnesium. That's very good thought. Yeah, I didn't put magnesium because even though some people use magnesium for clinical purposes, I don't think they're gonna ask you in the board exam about magnesium. But that's possibly a good point. Yes. So what do we do if we see somebody has a large kidney stone? Well, we can do surgery, get it out, or we can do shock treatment and try to break the kidney stone into smaller pieces that they can pass through it. And sometimes we can just put a catheter through the kidney and see whether we can pass through the catheter the kidney stone. So those are not things I don't think they will ask you, but they may ask you the complications of kidney stone. One is the obstruction of the kidney, and if that happens, then You just have to ask a urologist to put a tube for you because that's not going to go away and get rid of the stone for you. That would be a major complication of kidney stone, especially recurrent kidney stone, especially with people who have recurrent kidney stones and if they are kids. So RTA, those kind of things, I have to make sure that they're taken care of. And I think that's about all I know about kidney stone. Any questions? No? Very good. You guys are too smart. Yes, yes. It is it's a genetic disease in most patients. That's why that it's like there are some diseases in the kidney, like polycystic kidney disease, medullary sponge kidney, kidney stone, that if your parents have kidney stone, you would be at much higher risk of kidney stone yourself. Not necessarily you will get it all the time, but you would be at higher risk. Yes. All right, guys. That's it. Questions? No, thank you.